Welcome to the Deep Dive, where we unpack complex ideas into those crucial nuggets of knowledge. Imagine standing at a patient's bedside, their heart racing, breath shallow, eyes wide with a terror you can't see. Or maybe watching someone caught in an endless loop of rituals. How do you, as a nurse, navigate that invisible storm? Today, we're unlocking some profound insights from Varkarolis's Foundations of Psychiatric Mental Health Nursing. We're specifically diving deep into anxiety and obsessive-compulsive disorders.
That's right. Our mission today is really to break down these essential psychiatric nursing concepts, from pinpointing assessment cues all the way to implementing evidence-based interventions. And we want to do it in a way that's not just clinically accurate, but, well, completely accessible. We'll explore mental health assessment, therapeutic communication, the major disorders themselves, psychopharmacology, and maybe most importantly, how you actually apply these skills in real clinical settings.
Think of this as your shortcut. It's about equipping you not just for exams like the NCLEX, important as that is, but for the compassionate, holistic patient care that truly defines psychiatric nursing. We're preparing you for those critical moments. So what does this all mean for you, the future mental health professional? Let's unpack this. Okay, so to start, let's get really clear on what anxiety actually is. It's a word we throw around a lot, right?
Oh,
But how does
sure.
it truly differ from something like fear? And why is understanding that distinction so critical for nurses?
That's a fundamental question, really. Anxiety is, yes, a universal human experience, but clinically, it's a feeling of apprehension or dread. And it's often from a threat that's real or perceived. Now, crucially, it's distinct from fear. Fear is a reaction to a specific identifiable danger right in front of you.
Hmm.
Anxiety, it affects us at a deeper level. It's often described as sort of invading the personality, eroding self-esteem. But here's where it gets interesting. Normal anxiety. That's actually a healthy, survival-driven response. It motivates us to act constructively, like that nervous energy that pushes you to actually study for an exam.
Right, so it's not always a bad thing, but it sounds like it can quickly become debilitating. And that impact on self-esteem, wow, that challenges nurses, doesn't it? To look beyond just the obvious distress to those subtle signs of eroding self-worth, I mean, it suggests we're not just treating symptoms, but maybe helping rebuild a patient's core sense of self sometimes. So how do nurses actually identify when that useful adaptive anxiety crosses a line into something problematic?
You've hit on a key point there. Psychiatric mental health nursing really leans heavily on Hildegard Peplaw's classic model. She described four anxiety levels: mild, moderate, severe, and panic. Now, the boundaries, they can overlap a bit, sure, but identifying the general level is absolutely paramount for selecting the right interventions. So, with mild anxiety, your focus actually sharpens. You might feel, I don't know, a slight discomfort, maybe a bit restless, or you might see those mild tension-relieving behaviors like nail biting or fidgeting. Think of it as that heightened awareness you get before a big presentation, the kind that helps you organize your thoughts.
Okay, so that's the constructive anxiety you mentioned earlier. What shifts as it starts to ramp up?
Well, as anxiety increases to moderate anxiety, the perceptual field starts to narrow. Some details get excluded. Learning is still possible, technically, but it's definitely not optimal. And this is where those sympathetic nervous system symptoms really start to kick in. You might notice a pounding heart, increased pulse and respirations, sweating, maybe some gastric discomfort, headache, or even urinary urgency. Voice tremors and shaking can also appear.
Okay. And when it becomes truly overwhelming for the person, what marks that transition into severe anxiety?
With severe anxiety, the perceptual field is greatly reduced. The person might only be able to focus on scattered details, and often those details are distorted. Learning and problem solving. Pretty much impossible at this stage. The person might seem dazed, confused. Their behavior becomes almost automatic, driven just by the need to escape that overwhelming feeling. Somatic symptoms escalate, and there's often this profound sense of impending doom.
And the most extreme level, the most critical.
That's panic. At this level, the individual is completely unable to process their environment. They might even lose touch with reality. Their behavior can be erratic, uncoordinated, impulsive. You might see pacing, shouting, screaming, or sometimes complete withdrawal. Hallucinations can even occur. And acute panic. It can lead to sheer physical exhaustion. Understanding these levels is just fundamental for tailoring your nursing approach in real time. You have to know what you're dealing with.
That clarity on the levels is so helpful for clinical decision-making, definitely. Now, beyond these levels, people also have automatic ways of coping with anxiety, right? Often unconscious ways.
They absolutely do. Sigmund and Anna Freud wrote extensively about defense mechanisms. These are basically automatic coping styles. They protect us from overwhelming anxiety and help maintain our self-image. They do this by blocking distressing feelings, conflicts, or memories. But the crucial nugget here for nurses is recognizing that while these mechanisms protect, using them maladaptively often creates new barriers to healing.
That's a critical distinction. Can you give us a couple of examples? How can these mechanisms swing between being healthy or adaptive and unhealthy or maladaptive?
Certainly, let's take compensation. Adaptively, maybe a shorter man excels in business, kind of counterbalancing a perceived physical shortcoming. Maladaptively, someone might resort to excessive drinking when their self-esteem is low. They're seeking temporary relief, but it ultimately damages them.
Okay.
Or consider displacement. Adaptively, maybe a child yells at their teddy bear. After being bullied, they're channeling frustration safely. Maladaptively, a child who can't acknowledge fear of their father might displace that fear onto animals and become terrified of them instead.
So skillful observation allows a nurse to sort of see through the defense to the anxiety underneath. What are some other common ones we might see?
Another frequent one is rationalization. That's justifying illogical ideas or feelings. A maladaptive example would be saying, oh, I didn't get the raise because the boss just doesn't like me, when the real reason might be related to performance.
Making excuses.
Pretty much. Then there's suppression. This is a conscious but temporary denial of a disturbing feeling. So a student putting off worrying about their rent until after a critical exam, that's adaptive suppression. They'll deal with it later. Understanding these helps us assess how a patient is really dealing with their anxiety and identify patterns that might be holding them back.
Okay, let's transition them from these core concepts to the specific anxiety disorders discussed in the chapter, because these aren't just abstract ideas for you as nursing students. They represent real patients you'll encounter, each with their own story.
Exactly. And anxiety disorders are incredibly common, among the most common psychiatric disorders out there. We'll touch on several. First, there's separation anxiety disorder. This is a developmentally inappropriate, excessive concern about being away from a significant attachment figure, and it's seen in both children and adults. It can even show up physically, things like GI issues or headaches, and it often occurs alongside depression, bipolar disorder, or other anxiety disorders.
And then we have those really focused fears, the phobias.
Yes, specific phobias. These are characterized by an irrational fear of particular objects, activities, or situations. Common examples are heights, spiders, water, flying, enclosed spaces. The phobic thing triggers overwhelming anxiety and leads to intense avoidance behavior. It can really impact daily life profoundly.
Yeah, we've all heard stories, or maybe even experienced, how debilitating these can be. Like the example in the text, Daniel. After being trapped in an elevator, he develops such severe claustrophobia. He now avoids any enclosed space, even closets. That really restricts his life.
It's a powerful illustration of how pervasive these fears can become, absolutely. Then we have social anxiety disorder, often called social phobia. This is severe anxiety or fear provoked by social or performance situations, places where you might feel negatively evaluated by others. Fear of public speaking is a classic example. It leads to significant avoidance or just intense distress, making everyday social interactions extremely difficult.
It's fascinating how even people who seem really successful on the outside can struggle with this. You hear about public figures sharing challenges with stage fright or social anxiety. It really highlights that anxiety doesn't discriminate, does it? Okay, now moving to panic disorder. This often feels like it just comes out of the blue.
Yes, exactly. The hallmark of panic disorder is sudden, unexpected panic attacks. It's an abrupt surge of intense apprehension or this terrifying fear of impending doom. Typically lasts minutes. Patients often describe it vividly, feeling like they're losing their minds or even having a heart attack.
You mentioned they often come out of the blue, and that creates that fear of the fear, right?
Precisely. They start dreading the next attack.
So how does the DSM-5 specifically define a panic attack? What are those key symptoms we should be looking for?
Okay, so the DSM-5 defines it as an abrupt surge of intense fear or discomfort, and it has to be accompanied by at least 4 physical or cognitive symptoms. Things like palpitations, sweating, trembling, or shaking, feeling short of breath or like you're choking, chest pain, nausea, dizziness. Also, chills or heat sensations, numbness or tingling, feelings of derealization, like things aren't real, or depersonalization, feeling detached from yourself. And crucially, that intense fear of losing control or fear of dying. For you as nursing students, a key priority diagnosis during an attack could be something like severe anxiety, as evidenced by sudden onset of fear of impending doom. And a realistic outcome might be panic attacks become less intense and the time between episodes lengthens.
And what are the immediate crucial interventions for someone right there experiencing acute panic? What's the nursing priority?
Safety. Safety is the absolute priority. If they're hyperventilating, guide them. Slow, deep breaths. You have to keep expectations minimal. Keep your communication simple, because their ability to process information is severely impaired right then. Use clear, short statements. Maybe repeat them calmly. Try to help the patient connect feelings before the attack to its onset, if possible later on. Reassure them that the physical symptoms are anxiety-related, not some catastrophic physical problem like a heart attack. Teach abdominal breathing. That's a great long-term coping strategy. Promote positive self-talk like, I can control my anxiety. And, of course, educate them about any prescribed medications.
Okay. From that intense fear of a panic attack, sometimes that fear generalizes to specific places or situations. That leads us to agoraphobia, right?
That's right. Agoraphobia is an intense fear of situations where escape might be difficult or maybe embarrassing, or where help might not be available if panic symptoms start. This could be being alone outside the home, being on a bridge, in a crowded place, on public transport, or in an enclosed space like an elevator or theater. This fear leads to extensive avoidance behaviors that can become incredibly life-constricting. I mean, imagine someone unable to leave their house.
And finally, covering that more pervasive, chronic kind of worry, there's generalized anxiety disorder, or GAD.
Yes. The key pathological feature of JD is excessive worry. And it's worry that's way out of proportion to the actual impact of the events or situations. This chronic worry significantly impacts daily functioning. It causes fatigue, difficulty concentrating, irritability, muscle tension, and persistent sleep disturbance. It's exhausting. A priority diagnosis for GAD could be ineffective coping related to persistent anxiety, with an outcome maybe like patient will maintain role performance.
What are some core nursing interventions for a patient struggling with that kind of chronic, excessive worry from GAD?
Your presence is really key. Maintain a calm demeanor. Speak slowly, calmly, use short, simple sentences. Assure the patient that you're in control of the immediate environment, which can be grounding for them. Encourage them to discuss their feelings, clarify what they're experiencing, help them identify potential triggers for the worry, and encourage active problem solving for the stressors that are manageable. Help them break things down. Promoting physical activity is also vital. It helps relieve that physical tension that builds up from chronic worry. You're essentially working to help them reframe distorted thinking and maybe expand their perspective beyond the worry.
Okay, great. Let's shift gears slightly now, moving from generalized and specific anxieties into a related but distinct category: obsessive-compulsive disorders. What's the fundamental difference between an obsession and a compulsion? They're often linked, but they aren't the same thing, are they?
That's a really critical distinction to make. Obsessions are those persistent, intrusive, recurring thoughts, impulses, or images. They can't just be dismissed, and they cause significant anxiety or distress. They often feel senseless and really unwelcome to the individual experiencing them. Compulsions, on the other hand, are the ritualistic behaviors the person feels driven to perform. They do this in an attempt to reduce the anxiety caused by the obsession, or sometimes to prevent some imagined calamity they think is linked to the obsession. But the relief is only temporary, which inevitably leads to repetition. That's the cycle.
Got it. So the obsession creates the distress, and the compulsion is the brain's attempt, however ineffective, to neutralize it. What about obsessive-compulsive disorder, OCD, itself, then?
OCD involves daily symptoms, where these obsessions and compulsions are so severe that they become really time-consuming. We're talking hours a day sometimes. And they significantly interfere with daily life work, school, relationships, basic functioning. Common themes for obsessions often involve sexuality, violence, contamination, illness, or death. And these lead to compulsions like repetitive checking, locks, stove, excessive washing or cleaning, ordering, counting.
It's a condition that can affect anyone, right? Even high-profile individuals. The text mentions the famous soccer player David Beckham, who struggled with OCD. He had compulsions like counting his clothes and lining up magazines perfectly. It shows this isn't just a quirky habit, it's a consuming process dictating their life.
That's a great example of how profoundly it can impact someone, yeah. And beyond classic OCD, there are related disorders. Body dysmorphic disorder, BDD, for instance. This is characterized by a preoccupation with an imagined defective body part, even though they appear normal to others. This leads to obsessive thinking and compulsive behaviors like constant mirror checking, excessive grooming, or camouflaging the perceived flaw. Often, these individuals keep their struggle a secret because of profound shame, and tragically, the suicide risk is quite high with BDD. Next, there's hoarding disorder. This involves a persistent difficulty discarding possessions, regardless of their actual value. It leads to severe clutter that can make living spaces unsanitary, unsafe, and even uninhabitable. Indecisiveness is often a strong associated feature, and the condition tends to worsen with age, making normal life impossible for many.
It's hard to imagine, but yeah, the source describes how belongings can literally fill every surface. It prevents people from visiting, creates fire hazards, infestations. It's really unsafe.
Absolutely. It's a serious condition.
Huh.
Finally, we have trichotillomania, which is hair-pulling disorder, and excoriation, which is skin-picking disorder. These involve irresistible urges to pull hair or pick skin, often as a way to cope with stress or relieve anxiety. With trichotillomania, a specific serious concern is trichophagia, the secret swallowing of pulled hair. This can lead to hair masses in the GI system called the trichobizor,
Hmm.
or sometimes dramatically Rapunzel syndrome, which can actually be fatal if it causes an obstruction or perforation.
Wow, okay. So what actually contributes to someone developing these really challenging disorders? Is it all genetics? Is it environment? Or is it some complex mix?
It's definitely both.
Oh.
A fascinating blend of nature and nurture, really.
Hmm.
On the biological factors side, genetics certainly play a significant role. Anxiety disorders do tend to cluster in families. Twin studies, for example, show a strong genetic component for both panic disorder and OCD. Neurobiologically, the amygdala, that's our brain's danger alert system, is critically implicated. And neurotransmitters like GABA is inhibitory, it slows down neuron activity,
Hmm.
are a common focus for medication, as low GABA levels are linked to anxiety.
And what about serotonin? We often associate that with mood, but it's involved here too, right? And it gets kind of complicated.
It really does. Because while SSRIs, the common antidepressants, are designed to increase serotonin,
Hmm.
some research has surprisingly found that serotonin levels in the amygdala might actually be elevated in social anxiety disorder.
Huh.
Yeah. It's not just a neurobiological curiosity. It really reminds us that psychiatric meds aren't one size fits all. Their mechanisms can be incredibly complex, sometimes even counterintuitive. It absolutely underscores why individual patient assessment and a deep understanding of psychopharmacology nuances are vital for safe, effective care. Norepinephrine, which is involved in sensitization and the stress response, is also thought to be hyperactive in many anxiety disorders. Okay, moving to psychological factors. Psychodynamic theories like Freud's suggested unconscious childhood conflicts might be the basis for later symptoms. Anxiety results from repressed ideas trying to surface. Sullivan proposed that anxiety is linked to unmet needs in early life, and that it can even be kind of contagious, passed from anxious caregivers to infants, shaping their early emotional responses.
So those early experiences can truly shape how we respond to stress later on.
Precisely. Then you have behavioral theories. They view anxiety more as a learned response to specific environmental stimuli, something that can be unlearned. For example, a child anxious around an abusive parent might generalize that anxiety to all authority figures, maybe. But positive, safe relationships could help reverse that learning. The social learning model suggests anxiety is learned through modeling, like a child imitating a parent who's terrified of storms. And cognitive theorists believe distortions in thoughts and perceptions are the root cause. People tend to exaggerate mistakes and anticipate catastrophic results. And then there are crucial cultural considerations. It's so vital for nurses to recognize that how anxiety presents can vary culturally. Some cultures might express anxiety more somatically through physical complaints, others more cognitively. For example, attaque de nervios, or attack of the nerves, is a culture-bound syndrome seen mostly among Hispanic populations. It involves dramatic symptoms, sudden trembling, faintness, maybe shouting uncontrollably, even seizure-like activity. Often it's a response to a specific stressful event. This is different from typical panic attacks, which often come out of the blue. It just powerfully highlights why cultural competence is so essential in assessment and treatment. Okay, so now we get to where the rubber truly meets the road for you as future nurses, applying the nursing process to these conditions.
Right. So how do nurses typically begin their assessment? What are some key things to keep in mind?
Assessment usually begins by recognizing that most patients with anxiety or OCD rarely need hospitalization unless they're actively suicidal or their compulsions are causing physical injury, like skin breakdown from washing. It's absolutely crucial to first determine if the anxiety is primary, the main issue, or if it's secondary to an underlying medical condition like hyperthyroidism or maybe substance use or withdrawal. Always use the patient-centered approach. Remember, the patient is the expert on their own illness. Ask them what has helped you in the past. Using objective scales can be really helpful too, like the Yale-Brown Obsessive-Compulsive Scale, YBOCS for OCD, or the GAD Severity Measure, GAD-7 for generalized anxiety. These help quantify symptoms and track progress over time.
This brings up an important point for nurses themselves. Dealing with these conditions, which can be intense and often slow to change,
Yeah.
how do nurses manage their own feelings? How do they prevent burnout?
That's where self-assessment for nurses is critical. You will likely feel frustration sometimes. Behavioral change in these patients is often slow. Think about the rituals of a patient with severe OCD. They can significantly slow down even basic tasks, really testing your patience. Planning small, attainable outcomes, both for the patient and for yourself as the nurse, can prevent burnout. It also helps the patient gain a sense of control. You have to recognize that recovery is often a marathon, not a sprint, for everyone involved. It's a challenge we all face in this field, for sure.
Okay, so once assessed, then comes diagnosis and outcomes.
Correct. You'll use standard nursing diagnoses like anxiety, ineffective coping, chronic low self-esteem, maybe even self-mutilation if skin picking is severe. And you always link these diagnoses to specific, measurable outcomes. For example, an outcome for anxiety might be patient monitors intensity of anxiety using the 0-10 scale. Or for ineffective coping, it could be patient identifies multiple effective coping strategies to use when feeling anxious. Clear goals are essential.
And for planning and implementation, how does the patient's level of anxiety, which we talked about earlier, mild to panic, directly influence the nurse's approach?
It dictates absolutely everything. For mild to moderate anxiety, remember, the patient can still problem solve to some extent. So you'll use open-ended questions, broad openings, what's on your mind, exploration, clarification. Provide that calm, reassuring presence. Actively listen. Help them identify past coping mechanisms that worked. Encourage collaborative problem solving, and offer outlets for that nervous energy walking, maybe even ping pong if appropriate.
But what if the anxiety is severe or they're in a full-blown state of panic? The approach has to shift dramatically then.
Absolutely. For severe to panic anxiety, the number one priority shifts immediately to ensuring safety, yours and the patient's. Guide the patient to a quiet environment if possible to reduce stimulation. Use clear, simple, short statements. You might need to repeat them. Speak in a low-pitched, calm voice. Reinforce reality if distortions are occurring. I know you feel scared, but you are safe here. But don't argue with their perception. Attend to critical physical needs, offer fluids, encourage rest to prevent exhaustion. You might need to set physical limits if their behavior becomes unsafe, speaking in a firm, authoritative voice to provide that sense of external control they've lost. Provide opportunities for physical exercise later on to help channel some of that intense energy safely. Medications, or in extreme cases, seclusion or restraint, are only considered after less restrictive interventions have failed. Always the last resort.
And high anxiety levels can also severely impact basic human needs, right? Like self-care.
Oh, absolutely. Promotion of self-care activities is vital. Patients with severe anxiety or intense time-consuming rituals may neglect nutrition, hygiene, elimination, even sleep. As nurses, you have to provide structured support. Maybe offer limited choices. Would you like to wear this outfit or that one? If severe indecisiveness paralyzes them. Sometimes you might need to provide direct instructions for hygiene tasks. You need to monitor for skin integrity issues, especially with compulsive washing or skin picking. Create regular bathroom schedules if needed, and teach essential sleep hygiene techniques, consistent sleep schedule, calming bedtime routine, etc.
Okay, let's talk about pharmacological interventions. What are the primary medication classes nurses need to know about for these disorders?
Well, the SSRIs, selective serotonin reuptake inhibitors, like paroxetine, Paxil, fluoxetine, Prozac, sertraline, Zoloft. These are generally first-line treatments for most anxiety and OCDs. But it's really important to teach patients that they can sometimes initially increase anxiety before they start helping, which can be confusing. SNRIs, serotonin norepinephrine reuptake inhibitors like venlafaxine, Effexor, and duloxetine Cymbalta are also highly effective options.
What about those quickly acting drugs, the benzodiazepines? They seem like they offer immediate relief, which must be tempting.
They do offer rapid relief, which is why benzodiazepines like lorazepam, Ativan, or diazepam, Valium, are often used for acute severe anxiety or panic attacks. However, and this is a big Ugushin, however, due to the significant risk of dependence and withdrawal, they are typically prescribed for short-term use only, weeks, not months or years. Side effects can include sedation, ataxia, unsteadiness, decreased cognitive function, And sometimes, paradoxically, they can cause agitation or aggression. They're generally not recommended for individuals with a history of substance use disorders or for the elderly due to increased risk of confusion, falls, and delirium.
Are there safer alternatives for long-term anxiety management without that dependence risk?
Yes, thankfully. Buspirone, Buspor, is an alternative anxiolytic for long-term use. It doesn't cause dependence, which is a huge plus. The downside is it takes about 2 to 4 weeks for its full effects to become noticeable, so it's not for acute relief. Beta blockers like propranolol can be really effective for the physical symptoms of anxiety like a racing heart or tremors, especially performance anxiety. And some antihistamines like hydroxyzine are sometimes used as non-addictive alternatives for milder anxiety or sedation.
Crucially, what are the key teaching points nurses need to cover with patients about these medications to ensure safety and effectiveness?
Oh, patient education is paramount here. You absolutely have to caution patients against changing doses themselves or mixing these medications with alcohol or other CNS depressants. Advise them to avoid excessive caffeine as it can decrease the drug's effectiveness or worsening anxiety. Always discuss potential risks during pregnancy or breastfeeding with the prescriber. Many of these meds have risks. If a patient is on an MAOI, less common now but still used, stress the absolute importance of adhering to a tyramine-restricted diet to prevent a potentially fatal hypertensive crisis. And it is absolutely essential to warn patients about the dangers of stopping benzodiazepines suddenly. They need to be tapered off gradually under medical supervision to avoid severe withdrawal symptoms. Beyond medication, we also have psychobiological and complementary therapies to consider. For severe treatment-resistant OCD, surgical interventions like deep brain stimulation, DBS, are emerging as valid options in some specialized centers. When it comes to complementary therapies, nurses need to be really vigilant and ask patients what they're using. GABA, for instance, is sometimes used for anxiety, but it carries a significant risk of severe liver damage. It also inhibits the P450 enzyme system in the liver. That's the main detox pathway, which can lead to dangerous interactions with many other drugs, especially CNS depressants. So caution is needed.
Good point. What about advanced practice interventions, particularly psychotherapy? What are the main evidence-based approaches?
Right, these are usually delivered by therapists, advanced practice nurses, psychologists, or psychiatrists. Cognitive therapy is a major one. It focuses on challenging those distorted negative beliefs and assumptions that fuel anxiety. It uses techniques like cognitive restructuring to help patients identify, explore, reevaluate, and ultimately replace negative thought patterns with more realistic and adaptive ones. Then there's behavioral therapy, which uses several powerful techniques focused on changing behaviors directly. Modeling is where the therapist demonstrates a desired behavior, like approaching a feared object. Systematic desensitization involves gradual exposure to feared stimuli, while the patient uses relaxation techniques to manage the anxiety. It's very step-by-step. Flooding is more intense. It involves prolonged exposure to the feared stimulus until the anxiety response extinguishes. Not for everyone, obviously. Response prevention is key for OCD. The patient is deliberately prevented from performing their compulsive rituals to learn that the anxiety will subside even without the ritual. And thought stopping involves techniques to interrupt intrusive, obsessive thoughts, sometimes using a verbal command like stop or snapping a rubber band on the wrist.
And when you combine those two main approaches, cognitive and behavioral.
That's cognitive behavioral therapy, CBT. It integrates cognitive restructuring with various behavioral therapies. CBT is considered a gold standard treatment, highly effective for many anxiety disorders and OCD presentations. It gives patients practical skills to manage both thoughts and behaviors.
Okay, so after all these interventions, meds, therapy, nursing care, how do nurses actually know if they're truly making a difference? How do you evaluate success?
Evaluation goes right back to those patient outcomes we set during the planning phase. Is the patient reporting reduced anxiety levels? Are they able to recognize their physical symptoms or intrusive thoughts as being related to anxiety? For OCD, are the obsessions or compulsions less frequent, less intense, taking up less time? Can the patient effectively use new coping behaviors they've learned? Are they able to maintain basic self-care? Are they engaging in relationships again? Resuming their usual roles in life, work, school, family. Those are the real measures.
And tying this all back to continuous improvement in nursing practice overall.
Quality improvement efforts are really important here. This involves consistently measuring the severity of symptoms and monitoring progress over time, not just anecdotally, but often using standardized tools. Tools like the Clinical Global Impression Severity, CGIS scale, help clinicians rate the overall severity of the illness on a simple 7-point scale, from normal, not ill, up to among the most severely ill patients. Nurses are absolutely vital in gathering this data, observing changes, and reporting progress. This helps drive evidence-based care in mental health and ensures that our interventions are truly making a tangible difference in patients' lives.
Wow, we've covered so much ground today, from really getting into the nuances of anxiety levels and those often hidden defense mechanisms, all the way through the complexities of OCD and that whole array of nursing interventions available, from basic communication to advanced therapies.
And remember, understanding these concepts, it isn't just about passing your NCLEX, though that's important. It's really about developing the critical thinking skills, the assessment skills, the empathy to provide truly patient-centered, holistic care. And it's about feeling confident enough to step into those invisible storms with your patients.
Absolutely. Whether you're assessing a patient in the midst of panic, helping someone navigate a difficult compulsive ritual, or guiding them through basic self-care when they feel overwhelmed, every single interaction is a chance to apply this knowledge and make a real difference. The journey of becoming a mental health professional, it's about building both that knowledge base and your capacity for empathy.
So we really encourage you to reflect on how you might integrate these insights into your own clinical practice or your future practice. What challenges maybe stood out to you, or what moments of clarity did you have as you considered these really vital topics?
Keep learning, keep asking questions, and keep diving deep. You've definitely got this. We'll catch you on the next deep dive.